Thank you very much. Professor Sharma?
Yeah. So I think much has already been talked about keratoplasty, post-keratoplasty astigmatism, and so it may be a little repeat, but I would be talking to you about pearls in keratoplasty astigmatism. There are no financial or proprietary interests, and 15 to 30% cases of keratoplasty may have astigmatism more than 5 diopters, which is often irregular and is associated with higher order abrasions. And the early post-op may be there because of sutures in situ, and the late post-op may be there without the sutures, and this is governed by different factors. So the early post-op, which is because of the sutures in the C2 is because of symmetry of suture positions, depth of the suture track in the graft and the recipient, homogeneity of the suture tension. And the late post-op is related to the quality of the cut, the wound configuration, symmetry of graft placement, as well as wound healing. Recipient pathology does play an important role in post-PK astigmatism. For instance, it will be more for keratoconus than in Fuchs. Also in cases like with peripheral thinning or ectasia or focal edema or focal scar, or if there's vascularization or if there's a preceding keratoplasty or an eccentric graft, more so in aphakia, and also the topography of the recipient, possibly, especially if it is not normal in the periphery, may play an important role. The preoperative donor factors may also have a role to play. Age of the donor, because the infants tend to have steep corneas. Topography of the donors, although it's not a routine that is done in eye banks, and so you actually do not know the topography of the eye bank corneas which we are transplanting. Now, fixation rings, such as asymmetrically placed fixation rings, when we are doing the surgery, can induce astigmatism, and so can the lid specula if it is having it is putting a pressure which is not symmetrical. And the ring ideally should be, if you're putting a Fleringa ring, should be ideally equal distance from the limbus. 4 to 6 interrupted sutures should be put at regular intervals, and equal suture tension should be there to prevent undue astigmatism. Then as far as the trephination is concerned, endothelial side, you can have a round hole, but epithelial side, you can have a oval opening. And if the opening is not absolutely round, then again, this can lead to post-op astigmatism. The trephine types also play an important role. You can have handheld trephines or the suction trephine, and the Hesburgh-Barron trephine, where the recipient trephine has crosshairs for centration. And the donor trephine may get tilted, so that has to be avoided by 4 metal rods that are there corresponding to the peripheral holes for suction. Now, this is just to show how the centration of the center of the cornea is marked, and trephination of the host cornea is done using the marks which are there, so that you have a absolutely central and a circular trephination that is done, which is round and which is not oval. And if you are a novice surgeon, then it always helps to make those radial marks to help you to suture the graft. Then eccentric trephination can lead to irregular astigmatism, and the flat axis of the astigmatism is towards the direction of the decentration. Now, this is just to show a case of eccentric trephination with high irregular astigmatism of 13 diopters because of an eccentric graft. Of course, femtosecond laser keratoplasty trephination can also be done, and we can do it on the donor cornea also. The endothelial cell loss when you use femtosecond laser is 20%. Astigmatism is less than 3 diopters, and the patients do have early visual rehabilitation. And we did have a wonderful talk by Dr. Aldawe on this. So this is just to show that when you cut the, when you excise the cornea, your blades have to be absolutely perpendicular or vertical, and try and leave no ledge. And in case the ledge is there, which is left, then that ledge should be removed, especially the posterior part. And this is just to show the trephination which is done of the donor cornea, and the donor cornea is then placed onto the recipient bed. And of course, the first 4 suture placement first placement of the first 4 sutures is very important. All of these should be equidistant from each other, and you should have the classical quadrangle that has been described for this. And the sutures are then given on the previously placed marks. This would help, especially the surgeons who are learning to do keratoplasty. Intraoperative keratoscopy has a role to play, and some of the operating microscopes do have this reflex which can be seen while suturing, and so your sutures can be adjusted accordingly. Now, sometimes just by suture removal, one can help to decrease the astigmatism. And in this, the symmetrical sutures were there in DALC for keratoconus, and this astigmatism is about 2 diopters. And this is a combined and interrupted running suture, which has 2 diopters of astigmatism. But notice that there is some amount of ectasia also, which is present in the periphery. Way back, we published a paper where we compared torque versus anti-torque versus no torque suturing techniques, and we did not find any difference between these 3 types of suturing techniques. Then selective suture removal can be done like this, especially for astigmatism more than 4 diopters. And topo-guided selective suture removal starts at 2 months, and after the initial suture removal, the non-adjacent sutures can be removed at an interval of 4 to 6 weeks. Now, this is just to show how 5 diopters of astigmatism before suture removal has decreased to 1 diopter after doing the appropriate suture removal in the steeper direction. If you have a continuous suture which is causing astigmatism, then again, suture tying forceps can be used, and the whole tension can be redistributed from the area which is steeper to the area which is flatter, and this can correct about 2 to 5 diopters of astigmatism. And this is to show the pre-suture adjustment and the post-suture adjustment. The post-suture adjustment, the astigmatism is only 0.96 diopters. Of course, incisional keratotomy can be done, but this is done at 90% corneal depth, anterior to the graft hose junction in the donor cornea, and can be done manually or by the femtosecond laser. It does have low predictability and high incidence of recurrence, but it can correct in some cases up to 6 diopters. Compression sutures again have been described, but I think they are not again very predictable, although in high degrees of astigmatism, these can be used. Excimer laser surgery can be done after keratoplasty, so one can do a PRK if the cylinder is less, but one can also do LASIK, and these have been described as simultaneous procedure where with the help of the microkeratome or the femtosecond laser, a cut is made so as to release the tension, suture tension, which is there at the graft hose junction, and sequentially in the sequential procedure in stage 1, the femtolaser cut is made or the microkeratome cut is made. And in stage 2, 4 to 6 weeks later, the relifting of the flap is done and the laser is done. And this was an article which we published in Survey of Ophthalmology on LASIK after penetrating keratoplasty to treat astigmatism. Now, this was a case where femtosecond laser is being used to actually create a flap. And although this flap was almost a little beyond the graft hose junction, so the flap is elevated and is released back, is put back again. So the idea is that basically the tension forces which are present at the graft hose junction are released. And 6 to 8 weeks down the line, one can again relift the flap and then treat the astigmatism. Now, this was a case where we were trying to do this in a case of DALC, and we did see that there's some amount of retraction which is there. The arrow in the black, you can see the flap where it is there, and this is the arrow in the yellow shows the graft hose junction. So a little bit of retraction may be there in such cases. Of course, intrastromal corneal ring segments can be given for post keratoplasty astigmatism as well. And this was a case where toric intraocular lens implantation was done because there was also presence of cataract in this case, which was done post-DALC again. And after marking the axis, the intraocular lens is placed, and this would take care of some amount of astigmatism, especially the one which is lenticular. Of course, there is a caution for cases like DSEC, because if the astigmatism is high, then you, rather than doing a repeat DSEC, you should do a penetrating keratoplasty, because even if you do a repeat DSEC for a failed DSEC, with high astigmatism, the astigmatism is not going to get corrected. So to conclude, one has to have selection criteria which is stringent for donor corneas. Classically, this can be done historically from the attendance of any previous disorder such as corneal ectasia in any form. One has to take precautions intraoperatively in terms of centration, trephination, suturing, and keratoscopy, diagnose high astigmatism postoperatively, and take appropriate measures timely. Thank you very much for your kind attention.
Okay, wonderful. So I think